Potty Talk, Incontinence Issues and Pelvic Floor Dysfunction in Children, presented by Maura Plucino, PT, DPT, PRPC. Objectives. Today we will work on defining a pediatric pelvic floor physical therapist, review pediatric pelvic floor issues, explain examination of a child, review indications for pediatric pelvic floor physical therapy, explore pediatric populations at risk for pelvic floor dysfunction, review patient and family education topics, and experience and practice treatment techniques. What is a pelvic floor PT? A licensed physical therapist who has gone through specialized training to be able to evaluate, assess, and treat the pelvic floor muscles and associated problems. A pediatric pelvic floor PT will also have experience working with children of varying diagnoses with the added benefit of knowing about their urinary and digestive systems to help with belly and potty issues. Here are some examples of pediatric pelvic floor and incontinence issues. There can be storage symptoms, voiding symptoms, and other. Storage symptoms include increased or decreased voiding frequency, continuous incontinence, intermittent incontinence, enuresis or bedwetting, urgency, nocturia or frequent nighttime urination, constipation and encopresis, which is full stool incontinence. Voiding symptoms are hesitancy, straining, weak stream, intermittency, dysuria. Other include holding, incomplete emptying, post-micturition dribbles, spraying, or bladder, urethral, or genital pain. The PT exam. This begins with taking a detailed patient medical history. Review any notes, tests that are done prior to the PT evaluation from referring physicians. This may include the primary care physician, urology, or gastroenterology. Assessment of the musculoskeletal system. This includes screening posture, lumbar and SI screening, neurological screening, scar tissue assessment, Diastasis recti screening, and hypermobility screening. Visual examination of the pelvic floor. We are never doing internal work in a pediatric pelvic floor. Pediatric pelvic floor examination for a child includes external visualization of the appropriate sphincter action, asking the child to rest, showing a Valsalva and a contraction. We can also perform anal reflex testing, sensory testing. The child is always the boss, the parent is always present, and consent is always obtained. We will also review the basic bowel and bladder habits of the child with the child and the parents. And the PT exam can include review of a voiding diary on the first or second visit to rule out bladder irritants or bad voiding habits. For simple bladder issues, a bladder diary is recommended for 2 to 3 days, whereas for a food journal for bowel issues, a bladder and bowel diary is recommended for 7 days or more. How PT can help a child. They can help with bowel and bladder retraining, proper breathing mechanics, postural retraining, positioning during toileting, abdominal and pelvic floor muscle exercises, myofascial work including the abdominal wall, back, or hips, stretching and strengthening as needed, biofeedback, addressing general musculoskeletal impairments or dysfunction, and patient and family education. Pelvic floor issues can be present in a neurologically involved child. This can include, but is not limited to, these following diagnoses. Cerebral palsy includes a diagnosis that may have spasticity, may have an increased risk of scoliosis, may have poor postural control and movement dysfunction. Children with Down syndrome may have poor postural reactions, poor postural control, and therefore poor muscle control of the pelvic floor area. Children with autism may have poor sensory motor function, decreased postural control, slow bowels, increased risk for feeding dysfunction, which may cause constipation. Generalized gross motor delays can cause a child to have pelvic floor dysfunction because they can have decreased coordination of their pelvic floor muscles and their diaphragm, as well as limited postural control. Research studies showed that when children improved their postural control, they showed improved pelvic floor muscle control with their growth and development. Postural control is fully developed at age 13, as a reminder. Patient and family education that is common with a pediatric pelvic floor population includes body structure and function, bladder and bowel habits, vulvar and perineal care, daytime training and nighttime training, urge control and bladder retraining, constipation and stool management, and pelvic floor coordination and strengthening at home. The science. This is something that I typically review with a patient and their parents to help the child to fully understand all of the systems and why it is important for them to work properly together. So we review the urinary system, the digestive system, the reproductive system if needed, and the abdominal canister. So it can be a very simple explanation, such as the liquid is taken from our intestines and sent to our kidneys, and the kidneys filter out all the yucky stuff and send it down our ureters to our bladder, and our bladder holds the pee until it's time for the pee to come out of our urethra. As far as the explanation of the digestive system, I typically explain that we put food in our mouth, we chew it up and swallow it, it goes down our esophagus to our tummy. In our tummy, it mixes with gastric juices. The gastric juices turn it into sludge that moves into our small intestine, and our small intestine takes out all the things that are super important for our body, and then it moves it to the large intestine, and the poop moves to the large intestine starting at the ileocecal valve, and it moves up the ascending colon, across the transverse colon, down the descending colon, and then into our rectum. And when it moves into our rectum, it gives us the feeling that it's time to poop. This is the review of anatomy for a female patient. If we had a male patient, we would want a version that does not have a uterus, but it is sometimes helpful to show how all the things fit in together from the side, especially when we were dealing with issues of constipation. So I show the child or the parent or both how everything fits together, how we have our bladder with our urethra coming down, we have our uterus with our pelvic floor muscles coming down, and we have our bowels with our anus coming down. And our pelvic floor is a muscular sling that connects from our pubic bone to our coccyx, and it holds all those things up. I also explain that if our bowels are super crampy or super full of poop, that it pushes on our bladder, and our bladder is an angry 2-year-old that does not like to be pushed on and smooshed. This is our abdominal canister. This is the foundation of pelvic floor physical therapy. I'm sure that you have already been introduced to Mary Massery's work, but this is kind of a continuation of that. And I explain to patients and their family how they have 4 parts of their abdominal canister, including their back with their back muscles, their diaphragm and rib cage, their belly muscles, and their pelvic floor muscles, and how these all need to work together like a pressurized system, like a can of soda, and something that happens up here affects down here, here, and here in all of the areas. I also explain that when I'm doing an exam, I'm going to check out the back and the belly and the ribs and the diaphragm before we even ask to look at the pelvic floor. And again, I always remind the child and the parent that the child is the boss, and that if they're not comfortable with me looking today or ever, that is okay. It just gives me more information for helping. Healthy bladder habits for children vary based on age. So normal bladder frequency in the first year is about 20 times per day, which is why we change diapers so often. After age 1 to 3, that becomes about 11 times per day. That is in the typical potty training age towards the end of that range. Age 4 to 5, we typically are starting to go 6 to 8 times a day, which approaches what is normal for an adult. And our bladder capacity has increased by 400% by the time that we are in that age 4 to 5 range from when we were a newborn or in our first year. By age 12, we're going 4 to 6 times a day, which is the equivalent of what is normal for an adult. It is not normal to get up to go to the bathroom at night until you are 73 years old or older, or unless you're pregnant. Voluntary muscle control of the periurethral striated muscles, which are the muscles that control urine, happens around age 3. That is why age 2.5 to 3 is the perfect window for potty training. Daytime dryness precedes nighttime dryness by about 10 months. Therefore, a child could be potty trained during the day for 10 months before they are able to stay dry at night. A bladder and bowel diary is a log of what the child is eating or drinking and how their bowels and bladder are functioning. The log is a great picture of how these things are functioning, as well as their habits and patterns, and how their habits and patterns are influencing what is happening with the bowels and bladder. It records things like the time of day that they are going to the bathroom, the type of fluid and food that they're intaking, the amount that's voided of pee and poop. Pee is usually measured in seconds, and poop is usually just assessed as far as the consistency and texture, which we'll talk about later. If there was any leakage, it describes what kind of leakage it was and when it happened. If the child is able to describe urge sensation, it is recorded as a urgency of a 1, a 2, or a 3. And if there was any activity with leakage. So, for example, I treated a little boy who leaked every time that he went to football practice. He leaked stool. And so that was very important information for me because I knew that he was working very hard during this practice, and that was why he was leaking the stool. And we were able to work on his load transfer to make that stop happening. To see habits with the bladder, you need about 2 to 3 days. And to see habits with the bowels, you need about 7 days at least. Perineal care for a child is very important. Once we stop wiping our children, or parents and daycare workers or school teachers stop wiping the children, sometimes we see some interesting things happen in the perineum. So we want to make sure that there's proper cleaning. We don't need to use soap. We can use a gentle cloth and water. Water wipes are very helpful after toileting, especially when learning how to wipe. And we want to make sure that there's proper drying afterwards, especially in little girls who tend to be very moist in that area. Teaching a child to wipe properly is very important and will be very helpful with the child moving forward in life. We also want to allow time for airing out and letting air flow. So this includes wearing cotton bottoms and underpants, and also for little girls and little boys, wearing loose bottoms to sleep can be really helpful, and letting air get to that area and just keep things nice and clean and happy. Skin care, if needed, or a moisture barrier can be whatever diaper cream worked best for the child. There are lots of examples of this. It includes Desitin, Balm-X, Bag Balm, Aquaphor. And typically I just ask the parent what worked best for the child when they had diaper rash, and this is usually a good thing to try, especially if we're having issues of urinary or fecal incontinence. We want to avoid perfumes and irritants in laundry products. I know that my daughter has a very sensitive little bottom, and so we always have to use all free and clear. And if we don't use that, let's say she goes to grandma's house and grandma cleans her underwear, she ends up having some irritation because of that scented laundry detergent. Recommendations for potty training. So we, as a pelvic floor community, do not recommend potty training before the age of 2. Trying closer to age 3 is more recommended. 2.5 is the earliest that I usually recommend thinking about it. You don't want to start the process with deadlines, pressure, or expectations. A lot of daycares will require a child to be potty trained to move up in a class, and so this is where these things can become an issue for parents or the child. The child must not be constipated consistently for at least 3 months prior to potty training. So if someone comes to me and their child is constipated, I recommend that they take a break to work on stool consistency before we even consider the idea of potty training. Making sure that the child is able to use a toilet in a squatting position is important. The family needs to continue to monitor the child's bowel movements and check in, because we want to, again, make sure that stool consistency is staying good and not getting too hard or constipated. We want to make sure that the child will attempt to go every 2 to 4 hours. We want to also make sure that children are eating real foods that include fruits and veggies, because children who live on mac and cheese and hot dogs and chicken nuggets are going to be at risk for constipation, which will make the whole process of potty training harder. We also want to make sure that the child is showing signs of readiness. Signs of toilet readiness is that a child can dress or undress themselves independently or with just a little bit of help, that they're showing interest, that they like books and movies about potty training, that they are interested in picking out a potty seat in big kid underwear, that they notice when they're soiled or wet, that they notice that they try and hide while they're voiding, or they tell you that they're soiled or wet, that they tell you that they have to go. So they might wake up and say, I have to pee or I have to poop, and that they will actually stop doing an activity to go to the bathroom. Failure usually occurs when training is tried too early, or if the child really doesn't have these signs of toilet readiness. The voiding cycle. So the bladder fills and stores urine, and the detrusor muscle is relaxed during this. Transition is asking the child, how does the child know that they have to go? What do they feel in their body? And then there's bladder emptying, which is where the pelvic floor muscles relax and the detrusor muscle or the bladder contracts and expels the urine. During storage, the detrusor is relaxed. The parasympathetic nervous system is intact. The parasympathetic nervous system is inactive, and the sympathetic system activates the sphincter. So it's holding, the pelvic floor is holding the urine in, and the detrusor muscle is relaxing to allow the urine to fill it. And then when it's time for emptying, the detrusor muscle contracts, the parasympathetic system is active, and the parasympathetic system is inactive to the sphincters, which allow the sphincters to open and let the urine to come out. So this is a picture of a normal bladder with the detrusor that is contracting when the bladder is full. And then we have an example of an overactive bladder, which is where the detrusor muscle is contracting before the bladder is full and giving the signal to the brain that it's time to empty before the bladder is really full. So constipation facts. The prevalence of constipation, according to the literature, is 12% of children are constipated. In my clinical experience, it is much higher than this. It also might be that I just see a lot of the constipated children, but I deal with constipation in children very frequently. Lower urinary tract symptoms occur with constipation, 30 to 50%. Whenever I hear a child or an adult tell me that they have had frequent repetitive urinary tract infections and they do not have an anatomical reason for this, I immediately ask about their stool consistency, because in my experience, at least 75% of the time, there is a constipation issue going on that is causing this increased incidence of urinary tract infection. Bedwetting is almost always caused by chronic constipation. So if there is an issue of bedwetting, especially as the child is over the age of 5, we really want to be assessing for constipation. And a child can poop every day and still be constipated on x-ray. So we really need to be having these conversations with parents and the children about what the consistency of their stool looks like, how their belly's feeling, how their diet is, how their pooping habits are. Are they sitting in there for a long time? Are they avoiding going because it hurts? We really need to be having these open conversations about poop, because poop is very, very important in pediatric pelvic floor issues. Signs a child may have constipation. This can include extra large poops, which are adult size or clog the toilet. That's a red flag. Very firm poops that come out like logs or pellets. Poop accidents. And actually, when I have people who have children who have very firm poops and logs, it sometimes is accompanied by diarrhea. So they'll say, my child has rabbit pellets and then diarrhea. And I always describe that to the parent as the body's trying to clean itself out. So if they get too backed up, then they will end up having diarrhea because the body is trying to expel all that waste. So you might see a child that yo-yos back and forth from extreme constipation to diarrhea. That's still a sign of constipation. The child may have poop accidents, which could be a full emptying of their stool, or it could just be poop smears. They could have bedwetting or daytime pee accidents. They can have recurrent urinary tract infections. They can have extremely frequent and or urgent peeing, so they feel like they have to go all the time. They might have infrequent pooping, which means they might only go once a week or once every 2 weeks. They might be pooping more than twice a day, though. So they might go a little bit here and go a little bit there and go a little bit here. They might have belly pain, the skid marks in their underwear, or an itchy anus because there's constantly fecal matter irritating down there. They could have that super loose poop that it kind of typically cycles with that very firm poop. They could have continued trouble toilet training, so they could be age 4 or 5, or they could be hiding to poop in their diapers because that's the only way that they're comfortable going. They might have a decreased appetite, or they might have something called bypass diarrhea, which means that they have a lump of stool that's visible on ultrasound or x-ray, but they continue to have diarrhea and not pass that stool. So this is a picture that shows how constipation is bad news. The left-sided picture is a normal colon, and then the right-sided picture is a colon that we call a megacolon. I don't usually describe it to parents like that, but it's called a megacolon. And you can see there's this large lump of stool in there. It stretches the anus open so that the internal and external anal sphincters can't touch each other. So what happens is our poop train is always working. So poop is always being made by the poop factory and it's being sent down. So there can be this big lump of stool in here, but the soft poop can break off when you cough or sneeze or go to throw your football at football practice. That little bit of poop can smush out. Sometimes what happens is we get little pellets in our underwear. So little pieces of this might break off and kind of come out in our underwear. Or sometimes our rectum just says, I can't hold this anymore. And all this poop just comes out. Our rectum is supposed to be a sensory organ like our stomach. And so, like our stomach, it fills up to a certain point and says, hey, I'm full, I'm going to stop eating. Our rectum fills up to a certain point and then it says, hey, I'm full, it's time to poop. When children hold, and they hold and they hold and they hold, we no longer are a sensory organ. We now become a storage organ. And we start storing here and we keep all this poop in here. And then our rectum does not tell our brain when it's time to go. And then eventually the rectum just gives up. It can't hold anymore. And so the poop just leaks out. So that's kind of an important picture to keep in your brain when, dealing with kids with chronic constipation, because this is frequently where the issue is coming from. So this is a book called it's by Steve Hodges, and he has this whole program called the MOP program, which is the Modified O'Reilly program, and he's very into cleaning out via enemas and also using Miralax. But I really like these pictures, especially when I'm showing things to kids and their parents, because it kind of puts it all together for them. So there's two ways to clean out our bowels. You can clean out your bowels from the top down or the bottom up. So top down would be something that we take via our mouth. So different types of laxatives or stool softeners and fiber and water. And that helps to make this poop that's coming down nice and soft and smushy. But then a lot of times when we have that megacolon going on with that big lump of poop that's like hard clay, we need to clean out the poop from down here. So sometimes we can do that with manual therapy. Externally, we can work like on the rectal valve area and help to try and get that to move a little bit externally out here. But sometimes we do have to ask the family to get permission from their doctor to do things like an enema to help to soften the tissue and the stool that's stuck in their rectum. I love this picture, and I show these pictures to adults that have constipation or urinary urgency related to constipation. So this is just showing a picture of our bladder being smushed by our rectum that's full of poop. I describe the bladder as an angry 2-year-old. It wants to do things by itself. It wants to be left alone. It doesn't need help. It doesn't want to be touched. It doesn't want to be irritated. If you irritate it, it might throw a temper tantrum. A temper tantrum in a bladder might look like leakage. It might look like frequency. It might look like a full emptying. It might look like bedwetting. So we really want to make sure that we're keeping our rectum happy, and not our rectum, our bladder happy by keeping our rectum happy. So if we don't have this big lump of poop, then our bladder has more room to be happy and stretch out and not be squished. So where is your poop? Now this is very helpful for all ages, but I like this Steve Hodges version best, and you can just Google Steve Hodges poop chart or stool chart and it'll pop up. There's another version that has numbers as well, so it's whatever you prefer. And I give these out to parents laminated, and I have them stick it on the wall in their child's bathroom, because after our child is potty trained and are no longer wiping their bums, we are not typically seeing their stool. So it is very important for us to teach our child to report back to us if there's something wrong with their poop. So I always tell the story of how my daughter will be pooping and she'll scream to me, "Mom, my poop's wrong." And I'll say, "Okay, what kind of wrong is your poop?" And she'll tell me it's rabbit pellets or it's diarrhea or, "Oh, never mind, it's fine." Because our stool consistency is very important. And I've had people, I can't tell you how many times I have children or parents or adults that come in and say, I'm not constipated, I poop every day. And I say, great, show me what your poop looks like. Oh, my poop's like this every time. Well, that's constipated. You could poop that every single day and that's still constipated. That's not a good stool texture. So we are trying to get this type 4, even type 5 is fine, soft and smushy, and it comes out like smushy, mushy steaks, mushy blobs, and soft serve ice cream. So it should come out super duper easy once you get the urge to go and you're sitting. It should not be hard. It should not be big. It should not be filling up the toilet or clogging the toilet. So if we're having any of those things, we really need to rethink our stool consistency. And that's really hard for some people to come to terms with because they've pooped this way their whole life. And so they're not really sure. They don't really always buy in right away. But that's, especially with kids, it's really important to be working on this soft, smushy poop. So we're going to talk about medications. Remember, as PTs, we are not allowed to prescribe medications. We can only make recommendations to the physician or to the parents to talk to the physician about things that we might recommend. But as a pelvic floor pediatric PT, you might ask the parents what medications their child is on, because if they have a constipation issue, they're likely on medication, and see if we might need to make changes. Because believe it or not, we are sometimes the ones that are putting it all together, and we might have a different perspective because we get to spend more time talking about these things with parents than a doctor typically does. So some of the common ones that you'll see is Miralax, which is an osmotic laxative, which means that it brings liquid into the intestines. So it does not control when you go. It does not make peristalsis happen faster. It just makes the stool softer when you go. So I typically choose this over a stool softener like Dulcolax because there's not a lot of side effects with it, and it's not habit forming, and it's tasteless and colorless, so it's easy to put into like your child's morning drink. Milk of magnesia is another one that they will sometimes recommend for like smaller, younger babies. And if the child doesn't do well with Miralax, there's another one called lactulose, which is a prescription medication, which is also an osmotic laxative, and that one's like a sweet tasting syrup. So those are, oh, there it is. I'm sorry, I just saw it on my thing. So those are the 3 osmotic laxatives. So that is when we are having poops that are too hard. We want to think osmotic laxative to soften them. Then we have some children who have slow motility. So their parents will say, I feed them something and they don't poop for 6 days. So a good test of this would be like feed your child corn on the cob and then see when you start to see corn on the cob pellets start to come out. That should typically happen in 2 to 3 days. If it's more than that, that means that they have some slow motility, that the poop is moving through the poop chain very slowly. So sometimes we do need something called Senna, which is a stimulant laxative, and that stimulates peristalsis. It stimulates the muscles to squish the poop down and move it down. So this is typically like they make like I think it's called Pediatric. It's like a chocolate tab that the kids eat. And again, I'm not prescribing this. I'm, saying to the doctor, maybe we could consider a small stimulant laxative, and I let them make up the dosage and I let them make the recommendation for what product they want. But any product that has Senna in it is a stimulant laxative. And I have frequently had people come in that are taking tons of Senna, and I'm like, why are we taking all this Senna? Because Senna is habit forming and does affect the muscles, and it does not teach the bowel as well as teaching the bowel how to move properly with proper stool consistency. So my goal is usually to get the child off of Senna at some point because I want them to just be making bowel movements on their own. Magnesium citrate you might see more with like colonoscopy prep, and some of these kids are getting colonoscopy prep as a treatment, so they're getting cleaned out because they're so constipated. Metamucil and Benefiber and just like fiber over the counter things, those are all bulking laxatives. So sometimes I run into this problem where people think I need to take fiber because that will make me poop. And I'm like, yes, in theory, fiber makes you poop, but there are different types of fiber, which I think we'll talk about in a little bit. But, if you think about, you mix Miralax in a cup and you set it down and you leave it, it looks like water when you come back to it in 20 minutes. You set Metamucil or Benefiber in a cup and mix it, and you come back to it in 20 minutes, and it looks like Jell-O. Which one do you think is going to make your stool softer? Because my bet is going to be more on the Miralax than the Metamucil. So if we have someone who already has hard stool, I don't always want to add Metamucil or Benefiber to the mix because I don't want to bulk up their stool. I want to make it softer and smushier. But then sometimes I have the kids who have like, some sort of genetic GI thing where they've had surgery, like Hirschsprung's, where they're missing part of their colon or they're missing part of that peristalsis. So things are moving too quickly through their GI system. And then we want it to slow down. So then we want to put something in there to kind of bulk it up and slow it down. So then we want some, like a sludgy medication like Metamucil or Benefiber. So we really have to think about what our goal is when we are thinking of medications. And sometimes I think that practitioners are just like, oh, you're constipated, take some fiber. And that's not always a great blanket recommendation, especially dealing with kids and their little digestive tracts. There are also enemas and suppositories. An enema is something that's going to flush the rectum, like a small amount of liquid, and a suppository is going to be like a little thing that you put in there that just softens the poop, so that, like, if you put in a suppository at night, it might soften it in time for it to come out in the morning. Glycerin suppositories are typically what I would recommend for toddlers, again, under the pretext of asking a doctor first or having the parent ask the doctor first. They also make saline enemas, fleet enemas, or mineral oil enemas for older children. If you need to for a toddler or a baby, you can get permission from the doctor. They also make mini enemas. Again, that's kind of like a last resort, and that's for someone who's like really chronically constipated, who has a confirmed megacolon via, X-ray, ultrasound, anal manometry, defecography testing. So fiber requirements is going to be the age of the child plus 5 grams to the age of the child plus 10 grams until the age of 10. So for a 7-year-old, that would be 13 grams of fiber to 17 grams of fiber. After the age of 10, it's going to be about 25 to 35 grams per day. Another rule is 14 grams of fiber for every 1,000 calories that the child is eating. Insoluble fiber is the fiber that Teflon coats the stool to bulk it up. It's added if the stools are too hard. And then soluble fiber increases the stool's weight and absorbs water, so it's added if the stools are loose. So soluble fiber is your Benefiber, your Metamucil. Insoluble fiber is more like what people think of as roughage. So it's the things that kind of come out looking like when they came in. 25% of our diet should be soluble and 75% should be insoluble, because we don't want everything to be like a sludge, because then we're just filling our rectum and it's getting stuck. Foods that can help bind if we're having a child that's having issue with too loose of stool can be applesauce, arrowroot biscuits, marshmallow, banana, peanut butter, tapioca, cheese, macaroni and cheese, rice, bread, processed foods like chicken nuggets and hot dogs. Foods that bind, again, are these things. So if your child that you're seeing is only eating these things and they're constipated, we need to start adding in some new things. So take-home messages are that you can take a year to break a bladder or bowel habit, especially if it's a holding habit. Bowel changes I tell parents at least plan on doing this if it's working. Like once we get to the point where it's working, at least plan on doing this for 3 to 6 months. If you stop sooner than that, it's likely the bowel is a slow learner. So you really need to continue and consistently do it for at least 3 to 6 months. And then if you try and wean and you see a regression, you continue back with the plan. My daughter has chronic constipation. I started treating her when she was 4 because she potty trained very early at 2. And now I know that was a bad plan, but she chose to potty train at 2. And she had severe bedwetting issues for 2 years. And then we finally started treating her constipation. And it took another 2 years of taking medication and working very hard on her fiber and balance for her to be weaned off of that protocol for her bowels. Her bowels took 2 years to learn how to do that without needing help. And she still needs some help to balance things out. So, it takes a while, and we still have to be cognizant that as our child goes through growth spurts, or, they have a week on vacation and they eat like crap, that we might see regressions and that we need to make changes from there. We always have to address bowel issues before the bladder, whether it's pediatrics or adults. And it's going to be a multifaceted approach between the family, the patient, the PT, and the doctors. Children need consistency, they need positive reinforcement, and they need understanding from their care team. So I am always I don't call it accidents, I call them leaks. I never blame the child or the parent if they don't do something that I recommend or ask them to do, or if they forget to do something. I just praise them for the good work that they're doing. I work really hard to come up with a program that's gonna work for that family. So if their child only eats chicken nuggets and mac and cheese, can we mix in some vegetables into that? Maybe that's a child that I do let them have fiber supplements. Is there one fruit or vegetable that we could add per week? Do we need to do feeding therapy and, have occupational therapy involved in the sensory aspect of getting them to eat more fruits and vegetables? It's not always a straightforward answer, and sometimes you need to pull more helpers into your care team. Doesn't mean that you have to fix all the issues, but you might be the first person to say, like, hey, this kid only eats 4 foods, and this is part of the reason that they're having these issues. There's that. So then we're going to go over treatment techniques just real quick because we're going to do a lab on this. So treatment techniques that we're going to review include biofeedback. This is used for functional assessment, so we can see contract, relax, and bulge. It's used for proprioception to tell what the pelvic floor muscles are doing to the patient, the parent, and the therapist. It can be used for up training, which is engaging the muscles and strengthening, or it can be used for down training, which is relaxing the muscles, softening, and letting them be heavy. It's also very useful for finding a good potty pooping position or avoiding position if they're having pee problems. So the other techniques that we're going to do in lab will be finding the pelvic floor muscles in the core breath. So practicing breathing in and breathing out. And when we breathe in, our diaphragm should go down and our pelvic floor should go down. They work in opposition of each other. And when we breathe out, our diaphragm will go back up and our pelvic floor should come back up. So practicing breathing like that. Diastasis recti screening, and we can do a little bit of reviewing of how to treat that if you guys have not, but using 2 fingers to assess the abdominal muscles without tension in the tissue and then with engagement of the tissue by doing a chin tuck. I Love You and Abdominal Massage can be very helpful in helping children manage constipation or stool consistency. So this can be something that can be reviewed in lab. And then also just reviewing voiding posture, because this is so important because our kids are trying to poop on potties that are too big for them with seats that are too wide for the little pelvic floors to rest on. So we really need to be in a squatting position. This is why you see children beg for their diaper and run off and hide in a corner to poop, squatting down behind a piece of furniture, because that is a position that is comfortable to poop. So we want to be in a position where our hips are below our knees and we can rest and we can breathe. And some ways to engage this while they're in this position. This little girl is in a perfect position. This is actually a Squatty Potty Pediatric bundle that you can recommend for people to buy. It's adjustable, so this piece can come off. It comes with this child-sized seat that goes with it as well. But we can do blowing bubbles. We can practice a technique called big belly, hard belly, which is a good alternative to Valsalva-ing. We can practice another pushing technique called Ready, Set, Go. So it's kind of the same thing. It's just building on this and leaning forward. We can play with kazoos or doing a ball toss and hug. Sometimes too, as preparation for pooping, we'll do like a deep squat ball roll and play just to kind of get those pelvic floor muscles relaxing and ready to relax on the potty to poop. So as far as pediatric home exercise programs go, we are addressing whatever we're finding in the clinic that is not working. So if we do a pelvic floor muscle assessment and it seems like they're having an issue with strengthening, then we're doing pelvic floor muscle education, working on quick flicks, short holds, and long holds. And then we're also working on their core, their hips, and their gluteal muscles. When we need to stretch things, if things are tight, it typically is the core, the hips, sometimes the pelvic floor, usually more the core, the hips, the back. Our home program is always going to be most successful if we are doing it as part of their play. So we can, see what the child likes to do. Do they like to do dance? Do they like to do yoga? Do they like gymnastics? And then also just if they're littler, developmental positioning. And then some bowel and bladder retraining. And we want to get the whole entire household. And if they go to school, whether it's preschool or school, we want to have the teachers involved. And I usually will send a note to the child's social worker or their teacher and their school nurse or whoever is really going to be the one overseeing this to make sure that they're carrying over this program at home. and at school, because it's not going to help if they're just doing it at home and then at school they kind of put this child in a poor potty position or make them hold or aren't enforcing that they need to eat their healthy lunch. So that's important that everyone's on board. These are some resources, so you can always email me if you have specific questions about my presentation or you need specific handouts. And then these are just some other resources that are helpful for learning about the pelvic floor. So it talks about the pelvic floor muscles, the 3D anatomy, constipation and bowel issues. And then Herman and Wallace is a very good resource if you plan on getting into pelvic floor treatment, whether adult or pediatric. They have a wealth of information. Pelvic floor 1 is the place to start, and then there's lots of other ways that you can branch out and get involved in the whole pelvic health world. So those are some resources.